ACL rehab is no joke. Like you can mess it up. You can't really mess up like a grade 1 ankle sprain theoretically. Like you'll be fine.
Yeah. Yeah, I agree.
But you can really mess up an ACL.
Big time, big time. And what's shocking is how frequently that happens because, I mean, I'm more shocked if I get a kid that comes back from college and their knee looks great, like exactly where it should be. I can't say I've ever seen that, honestly. Like,
Hey everyone, welcome to today's podcast. I have a very special guest. I have Bobby Esbrandt on today's show. He is a co-owner of Impact Sports Physical Therapy located in Hanover, Maryland. Just a little quick background about Bobby. He is a graduate from the University of Maryland School of Medicine, which is in Baltimore. He has a special interest in manual therapy and sports rehab, which if you guys follow his Instagram, you'll see he's working with a ton of athletes, which we will get into. He has experience treating numerous professionals, college and Olympic level athletes. So he has, his experience is expansive. So I think we'll have a lot to learn from Bobby. Welcome to the show, Bobby.
thanks for having me, Wes.
Cool. And Bobby, we're going to kind of just hop into things. Do you mind just kind of giving us a little bit of background about, your PT journey and what led you to open your facility?
Yeah. So, I mean, growing up in high school, I always had an interest in medicine. I knew I could never be that kid that, was going to sit behind a desk for 40 hours a week. That's just not in me. But, I played basketball in college. I was fortunate to do that. And, unfortunately I had a lot of injuries during my college career. I had my fair share of PT. So that kind of opened up the door to physical therapy for me. I liked my experience, but there was still, even then I remember sitting there and going through it and thinking, there's got to be more to it than this. But I started teching in college, working for a guy in college, and was fortunate to get into school. And yeah, I mean, I always knew I wanted to go the sports route. My first job out of school, I think like a lot of people, was anything but a sports route. I mean, I'd sit there and it was a private practice, so it wasn't a big like Miller chain, but I vividly remember I had one other young guy that worked with me, and going down my list of patients for the day and just, calculating the average age, and, it'd be like 68 or something of the average age of the patient. And, so, I mean, I kind of ran that course there. I was there for about a year and a half. Great boss, great everything. But like I said, it just wasn't what I wanted. I had the opportunity to go and work for another private practice up in Baltimore City that was much more sports based. Again, I was there for about a year and a half. And after about 3 years of being out of school, just decided with one of my buddies, I mean, it was time to do something ourselves. And so we started Impact Sports Physical Therapy about 2.5 years ago. And it's been a heck of a ride already, but yeah, that's kind of what's brought me here.
Gotcha. Yeah. And I know that before we even hopped on the podcast, I told you I already steal a lot of your stuff and use it with my patients all the time. And I think that's honestly the cool thing with the whole social media realm when it comes to PT world, because I mean, you and I have never formally met, but I also feel like I know you to a certain extent already.
Yeah.
Just because, I mean, it's just crazy how social media works nowadays and how we were able to just kind of pull this off and get you on the episode really quickly. And I know that you see a lot of ACLs, a lot of your posts are ACL related. And do you mind just kind of saying like, why you enjoy treating ACLs?
I love ACLs for a couple of reasons. I mean, number one, it's no two are the same. So, it's not like I'm sure you saw your fair share of total knee replacements back in the day, and, it's kind of mindless in the way it goes. ACLs, they're a little bit different. You don't really know what you're going to get. You could have the same patient go in, have the same surgery twice. And I feel same surgery, they could have a completely different result both times with how they respond. Some of these come out, they're very, very stiff. Some come out and, they look beautiful from day one. And so there's that aspect to it. I also like just the length of the rehab, being able to spend that much time with the patient over a course, it's always interesting to see their mindset pre-op to immediately post-op to, when they get up to be able to walk, once they start jogging, and then taking that all the way to the point where they're getting back to sport and seeing that. I think that aspect of it is pretty special.
Yeah. And I know that, I see a lot of your posts on your story and stuff and how you go and support your athletes and watch their games. And I think for me personally, that's just, to me, it's one of the best things ever is to see them go from, I talk about like unraveling the knee for the first time and seeing all the blood and the
Yeah.
stitches and all that kind of stuff. And
Yeah.
then, 9 months to a year plus of hard work, and you just keep working, and you get back to the point where they're back playing, basketball, football, whatever sport that they're going to see. And I know that, you are also the head physical therapist for Coppin State University,
Hmm.
and, you work with a lot of high school and college level athletes. And do you mind just kind of sharing the experiences about that too? I know that you and I talked about it briefly, how not a lot of people understand kind of the grind work that goes behind working with high level athletes.
Yeah. So I mean, I think the thing that's helpful for a lot of people if they're going to work with high level athletes is understand the mentality of these athletes, right? I mean, they're going to be a little bit different from the start. It's not going to be like Mrs. Jones who just had her hip replaced and is coming to PT for social hour. I mean, these patients they're very type A. They have something they want to get to. They have goals they want to accomplish. They want to understand why they're doing what at that point, what that's going to lead to, and they want to know the full plan. Um, at the same point, if they have one little hiccup or one little thing, it could be like they're falling over the edge of the earth. It can be catastrophic to them. Um, so it's very time intensive, I would say. Um, so you have to make yourself very available to them, which is good, but then it can also weigh on you as a clinician because, you know, you just get stretched thin at times, especially if your caseload's filled with that kind of stuff.
And just for the people listening, do you mind saying what time you normally leave the facility at night?
Man, that varies. I'm usually always the first one in. I'll start my day at 7 a.m. in here treating. Um, there's times where I'm not out of here until 8 o'clock. I know summertime where we're especially busy. Um, I'll do 12s Monday, Tuesday, Wednesday, Thursday, and then an 8 on Friday. And I think my biggest issue is I can't say no to people. So I'm always in there, and that's just what it is. I mean it's fun because it's something like you'll agree, like you always want to work with athletes, and once you get to that point, it's hard to let go. I know in my mindset, I always think back and like, well, geez, that first job I talked to you about with all the old ladies, I'd kill to have the opportunity to treat some of this stuff. So I always take myself back to that point, and um, that brings me back to it.
Yeah, I think reflecting on where we were, I was in the same situation. I saw a ton of total knees,
Yeah,
rotator cuffs, shoulder replacements, all that kind of really fun stuff that I
yeah,
don't see anymore at all.
uh-huh.
Yeah, I'm the same. Like I think the earliest I will ever leave is 7 o'clock, and on most
Hmm.
days I'm there until 8 o'clock. I don't get there at 7 a.m. like you do because I would never wake up. I'm just not a morning person. But like I'm the same as you in the summertime.
Yeah.
I'm seeing a lot more volume just because there's so many more college kids that are back, and I'm
Hmm.
sure you're probably the same. It's just
Hmm.
you got to get them in, and I don't want to treat 40 hours a week. Like I'm more comfortable treating like 30 to 35. But like you said, it's hard to say no to some of these people that kind of seek out your services, particularly like for me. And it's just like they want to see me for ACL. It's like, how do I say no to them?
Yep.
Especially if
Yeah.
they're in like the Healthy Ball network, and it's like I really can't say no to you.
Yeah. I mean,
And
when you're a young clinician, you're trying to grow a brand, you're trying to grow your company, you're trying to do that stuff. I mean, every patient that wants to see you, that's an opportunity to grow a little bit more and to
yeah,
get your name out there, help your business and stuff. So yeah.
yeah, 100%. And I think just going back to what you're saying earlier with like the athlete's mentality is that a lot of my athletes, they'll be like, how many days, they'll ask me like, how many times can I come in? And I'm like, on average for ACLs, like probably 2 or 3 times. Like, no, can I come
uh,
in like 5 times a week? Like, no, you don't really need to be coming in 5 times a week.
yep.
Like your body needs to, if we're doing enough in rehab, which, looking at your stuff, like we're pretty similar to the way we treat, like you're going hard for like an hour and a half,
Hmm.
and you should feel like you want to rest the next day. You shouldn't feel like you want to come back for more. And I think
Hmm.
that's the thing that we'll kind of dive into more, where more traditional level places, like it's hard for them to really load and challenge athletes to the capacity that they need to be. And I think that that's one of the bigger cultural shocks when it comes to like what sports rehab really looks like. And I think that was a big culture shock for me when I jumped into Healthy Baller and starting to, learn from Teddy and stuff, where I was like, whoa, like this is really what athletes need to go through, and learning about their college programs, their college lifts, their run tests.
Mhm.
and making sure you're accommodating all that kind of stuff into the rehab, which is stuff that obviously like you and I deal with on a regular basis that most people don't really grasp. And I didn't grasp until I, got into this world of like what we consider real sports rehab. So I just felt
Right.
like it was a cool thing for you to share your perspective, because I know you see it just a ton of, really, really high level athletes that most people kind
Yeah.
of, they dream about.
Yeah.
Yeah.
Yeah. It's pretty cool.
So kind of hopping back into the ACL train, and what are your thoughts on bracing when it comes to going back to sports?
I always keep it pretty simple with my athletes. I tell them I'm not a fan of bracing in general. Um, I'm of the mindset if I did my job right, if they put in their work right, then you should be fine. At the same time, you'll see a lot of surgeons and the patient feels the pressure from the surgeon. Well, he says I really need to use it. And so I always tell the patient, look, wear it. If you love it, if it gives you, some sense of comfort wearing that, great. Keep with it. If you wear that thing and it feels like you're being shackled, ditch it. You're going to be fine. So I try to not make it a big deal with them. And generally that seems to work. Some will continue to wear it and some don't. It's kind of split down the line.
Yeah, I think I pretty much agree exactly with what you just said. I never really push it on anyone. If the surgeon doesn't say anything about it and they leave it up to me,
Yeah.
then I'm just like, we're going no
Yeah.
brace then.
Yeah.
But at the same time, I had some, especially my college level athletes, where their schools will require them to wear it for the first season back. And then if that's their policy, then I pretty much were like, okay, well, we have to wear it. We have to make sure you wear
Hmm.
it when you're cutting and doing reactive work, because you got to feel
Hmm.
as comfortable as possible. No one's ever gonna love it. You're still wearing this thing that's strapped to your leg that's going to feel a little bit different. But like you said, just making them as comfortable as possible, I think is probably a big part of our job also, especially if the surgeon or school requires them to wear it.
Hmm.
Um,
Hmm.
and a little bit shifting a little bit, but what is your hardest ACL case that you've ever had?
Ooh, I would say it was probably last summer, or this past summer. I had a girl come in. She plays Division I basketball down in Florida, and she was 3.5 months out of ACL surgery. She came back. We're talking middle of May, and literally a 25-degree extension lag at 3.5 months. Like me, like I'm sitting, I've never seen one quite like that. Like, yeah, generally you'll see one, maybe you're missing 5, maybe bad 10. This thing's 25. Like, I didn't know what we could get it to. So I'm literally sitting there and I'm texting different surgeons. I'm like, what are my options here? Like what are we doing? And I mean, it was a grind. I mean, the girl was a workhorse. She was just, like I said, I don't know what they were doing for her. She was doing stuff with the athletic training staff down at school, and obviously not doing anything she was supposed to be doing. But I mean, we got her. I remember by the time she got back to school, we got her to neutral, but still so much discomfort in that knee. She ended up getting it scoped when she got back down to school, and that freed the thing up a little bit more. Um, but yeah, that was probably the one that's left me the most puzzled and head scratching. Is like, how did this happen?
Yeah, and I think it's funny because I actually am like currently in the middle of writing a blog post about why it's so important to just set the foundation. Full
Hmm.
range, flexion, extension, quad contraction, swelling. Those are my 4 like basic
Hmm.
fundamental pillars of it. And I think people get too eager about doing other stuff. Like honestly, even like bridges and clams. Like if you
Hmm.
can't get your knee straight, like I could care less about you doing a clam right now. Like let's just get
Yep.
this thing straight. And I'm guessing based on that girl, she probably wasn't being fed the right information. And I think it is important, and I think you probably do the exact same thing as I do, where you educate the patient like this is extremely important. Set
Yep.
the foundation, do this a ton throughout the day, and then we can build off of that. And unfortunately, with that girl, and I've seen that what you just told me, your story reminds me of a young girl, 14-year-old girl that I saw. Unfortunately, I didn't finish rehab. Her parents decided just like she was good enough, so they pulled her. She was 14 years old. She came into me with a 15-degree extension lag. And worst part of the story was the fact that she was discharged from her previous physical therapy because they told her that she could do the rest of her rehab on her own.
There you
So,
go.
you know what I
Yep.
mean? This 14-year-old girl who doesn't have any clue about how to do exercises, they just told her to go do on her own. And I was the same as you. We just worked at it and we just got her to neutral. And I was like, this is way better than where you were. and her mom was kind of happy with her being back at neutral. And then I wrote her up a program, and I just unfortunately haven't heard from them ever since. But it's not like I felt great about it, but I felt better the fact that we were able to get her to at least neutral. And it's still, I think that anytime I hear these stories or I see these people come in, and I'm sure you see a lot of people who are, 3-4 months post-op, and you're kind of like, what did you do over the past 12 to 16 weeks? And it's always it's challenging because you're trying to balance, like, not delivering them bad news about, like, hey, yeah, you are technically 16 weeks, but you look like you're like 6 weeks. And I hate having that discussion with these athletes. And it's just, I try to be as honest as possible when you're talking about this stuff. And it's like, you don't want to bash on anyone, but that's kind of where my whole thing that I talk about a lot, where it's like, ACL rehab is no joke. Like, you can mess it up. You can't really mess up like a grade 1 ankle sprain, theoretically, like you'll be fine.
I agree.
But you can really mess up an ACL.
Big time. And what's shocking is how frequently it happens, because, I mean, I'm more shocked if I get a kid that comes back from college and their knee looks great, like exactly where it should be. I can't say I've ever seen that, honestly. like, have you seen that yet?
I haven't. Not common. Yeah. It's the same stuff where it's just, they have neutral, and then the other knee has like 5 degrees of hyperextension, which is pretty common in female athletes. And they're told so many times that you're good enough. And then inevitably they're starting to do plyos, and then it's like, oh yeah, my knee irritates me. It's like, yeah, maybe because you're still missing 4 or 5 degrees of extension. And like, I think it ends up making such a big difference. It's okay for walking and all that kind of stuff, but once you really get into the running, the cutting, and the jumping, like, that's when it really starts to aggravate people. And then you go from supposedly being at 4 to 5 months, and you have to start backtracking, and that's when rehab gets really challenging.
Just because there's no logic with how they're progressing them. And so, I mean, you end up like I had a girl just walked in last week, and Division I basketball player, 5 months out, ton of pain in the front of her knee. She started running, she's doing some cutting, she's doing single leg jumping. This girl hasn't squatted more than the barbell yet. She's the Division I basketball player. Like, we haven't loaded that limb at all. I mean, she can't even squat down to a knee high box without collapsing. And so it's frustrating. I'm sure you agree with this. It's frustrating to see that stuff. But then it also, I mean, in a way, it helps us, because people will come and they'll seek us out from this stuff. But it's head scratching, because stuff like this shouldn't happen. Like, ACL rehab, like, it's intense, it's long, but it's not rocket science. It's just follow the steps, bring it along, see how the person reacts to what they're doing, and take it from there.
Yeah. And I think that later on in this episode, we're definitely going to dive into kind of, why retear rates are so high and stuff, but we'll definitely get into that. And, as far as the next question goes, what are your, we know the return to sport process is very rigorous, and it's honestly pretty complex, but like, what are your big tests for you as far as return to sport?
We'll look at a lot of things. I mean, we'll do all the hop testing. We'll make sure their range is good. I'll do a single leg squat test. I don't have any other like good way to measure single leg symmetry, strength side to side. So I'll do it in both a loaded capacity and also an unloaded capacity. I'll look and see what their 1RM is with a back squat, with a deadlift. I'll throw some Y balance in there sometimes. I like grouping a lot of different things together to see where they're at, and then we'll compare that stuff to some of either the high school norms for their gender or the college norms. And I think it helps them as well, especially when we're talking about these high level athletes, these type A personalities, where they see how they stack up. Because, I mean, you said we'll get to it, but I think one of the biggest pitfalls with ACL rehab is, you go to some of these run of the mill places, so you can jump on a 12-inch box, you can jog, great, go play basketball, see how you do, you're fine. And it don't work that way.
Yeah. And I'm guessing you're probably very similar to me. Is, if I were to ask you, when was the last time you looked at an ACL protocol? I'm guessing that you haven't stared at one in who knows how long.
No, not a chance.
Just out of curiosity, do you guys have a Kaiser at your place?
We don't.
You don't? Okay.
We don't, no.
That's how I use to test quad strength between the two sides. I just hook them up like a knee extension, and then just go non-ACL side first, and then compare it to the ACL side. It's a nice tool, because like you said, like, I think because athletes are pretty type A, they want to know numbers, and you can show them numbers. And I think at the end of the day, it's our job to prove it to them, whether or not they're ready or not ready. It's the cliche of like saying like we want to be testing and not guessing. And I
Yep.
think a lot of places they just kind of like they follow this ambiguous timeline of 6 months. Oh yeah, you look good, and it's like okay, well a lot of people look good at 6 months,
Yeah.
and it's just there's no thought process behind like a structured, systemized way of testing. And I make sure my athletes are testing and passing these things multiple times. It's not just a
Hmm.
one-time thing. Like you got to pass this thing 3, 4, 5 times before I think about clearing you to go back.
Hmm.
And it's like I said, it's a very systematic way of doing things, and every athlete again needs to be treated a little bit differently, but at the same time the structure of the return to sport is relatively the same for every single person. And that's kind of leading me
Exactly.
into the next question is like, what is your usual plan? Let's say an athlete starts to look really good, they're past that 9-month time frame, all that kind of stuff that we love to wait for, and they're starting to pass a lot of these tests. Like, what does your return to sport process look like?
I think it varies for everyone, but I like to get them into practice a little bit, bits of practice. I think too often people just get thrown out there. Okay, you're good to go. I think as much as we want as clinicians to believe that we can replicate, the action of sport, it's hard.
Hmm.
You can only do so much, because just that open environment of game where you're reacting to bodies and balls and all sorts of different stimuli. That's just a different beast. And then when you're in a fatigued state as well, we can get close in rehab, but nothing's the real thing. So I'll start them off with a lot of the non-contact stuff in practice, seeing how they're doing, and then it'll vary on the individual how they do. We'll gradually get them into certain drills. We'll okay certain ones, and gradually we'll ramp up minutes, and over time they're back. It's nothing overly complex. Just kind of taking it as that.
Yeah, I'm pretty much the same way. Like if they go through a good amount of practices, like full practice, and start to feel really good, then we start introduce game time, and I might
Hmm.
have them go 25% of the game at one time. So if it's 10-minute quarters, you're playing for 2 to 3 minutes, and then the reason why at least I do it that way is because I don't want them. Inevitably, their endurance is not going to be quite there yet, and I think that it kind of reduces the concern level to a certain extent if you keep it at 2 minutes. So let's say 2 out of 10. So you're looking at 20% of the game, and then you want them to just go hard. That's all I ever say. Like when you're in there, just go hard. Don't think about it, because you're gonna get pulled after 2 minutes. And I have found that that's kind of the best way, because they're still getting that like really fast paced, intense
Yeah.
work, but they understand like, oh yeah, I don't need to really worry about fatiguing too much because I'm gonna get pulled. And then you do it for a couple of games, you feel good. Let's increase it to 30, 40%, and just keep going up and build up to
Hmm.
that 100%. And like you said, it's not super rocket sciencey, but it's still structured in a way.
Yeah.
And I think painting that picture for the athlete early on and setting expectations. So it's like, I think the common misconception is that when you are return to sport, that means that you are full go return to sport, and that is not the case. It's got to be easing them
Hmm.
back into it, because I've seen that some people who get thrown in like full go, then they'll start developing like shin splints or
Yep.
patellofemoral pain that really doesn't make any sense. It's just
Yep.
like you said, you can't replicate that same amount of impact as a full-on practice. Like I had a girl who go back, one of my basketball girls, and I have a feeling that it might have just been because it was like a different surface. But when she was running on turf, like she would run a ton after our sessions, no problem. And then she went to school and started practicing with her team. She was a freshman, and then she started developing shin splints. And I was like, is it because like the pounding that was just on her knee? And
Yeah.
like she went full go because she was feeling really good, and they didn't really build her up to it. So she dealt with shin splints her freshman year, unfortunately, and it's tough because shin splints don't go away. And it's like, could that have been avoided if there's a little more of a buildup? And I think that's the
Yep.
other thing they don't look at. They just look at the ACL. They don't look at like, oh, she's still a human and an athlete that needs to gradually be
Hmm.
exposed to it. So I think you and I are definitely on the same page with that.
Thank you for watching today's video. Please feel free to like and subscribe and share it on your social media platforms. If you're interested, I have started an ACL Mastermind group, which is a growing library of content centered around ACL rehab. It has exercises ranging from immediate post-op to late-stage sports-specific movements and everything in between. It's a growing library and currently holds over 250 videos. There's content centered around assessments, movement breakdowns, exercise breakdowns, case studies, and a whole lot more. You also gain access to a private forum where you can engage with like-minded people, ask questions, share research articles, and share resources. If you're interested, please feel free to click the link below. Thank you for watching.